All right, let's go ahead and get started. Well, good afternoon, everyone, and welcome to the GW Global Clinical Care Alliance quarterly webinar. My name is Gavin Truong, and I'm delighted to be your host for today's session, titled Learning Locally, Thinking Globally, Educational Opportunities in Refugee Health here at GW. But before we begin, I'd like to extend a special thank you to Dean Bass for her support of the GCCA, as well as our co-founders, Dr. Kate Douglas and Dr. Gail Rousseau, for inviting us to lead this very important conversation. So before we start and throughout the session, feel free to drop in any questions that you guys have in the chat, and we'll probably have some time for some Q&A with our panelists at the end. All right. Next slide. So just a quick trigger warning. This is not going to be a political issue that we're not going to reinforce politics, although politics is involved. This is today going to be an issue on human rights. Next slide. So as in a webinar on educational opportunities, I would be amiss not to give you guys some learning objectives. So by the end of this webinar, you should be able to describe the U.S. landscape of refugees and asylum seekers, including the socio-political factors that impact their health. Explain how educational initiatives at GW provide hands-on learning experiences in the care and advocacy of displaced populations, and reflect on the role of healthcare professionals and students in addressing the unique medical, psychological, and social needs of refugees and asylum seekers through clinical care, forensic evaluations, and policy advocacy. Next slide. So without further ado, here are our panelists. So you have me. I am going to be moderating and hosting today's session, and throughout the session as well, I will be kind of introducing everybody a little bit more in detail. But briefly, we also have here Dr. Tanuja Devaraj, who is an HIV specialist and longtime refugee health educator that works at Whitman Walker. And then we have Dr. Sonal Batra, who is our associate professor here at the Department of Emergency Medicine and a longtime forensic examiner for asylum seekers in the DMV. Next slide. And here we have our med student panelists. We have Marwah Shuaib, Avery League, Amy Yee, and Shruthi Voleti, who will be sharing about their learning experiences with refugees and asylum seekers in the DMV. And I think that's something that makes today's webinar so special is their voice. Given our session is on educational opportunities, it's only right to elevate and highlight the experiences our medical students have with forcibly displaced populations and explore how these experiences at GW are shaping their learning and understanding of global health issues right here at the local level. So as you can see, the GCCA has done a very successful job uniting and connecting incredible people across all generations and specialties who have this very like-minded global health interest, and it provides us the ability to have introductions, network, and provide opportunities for collaboration, which is definitely the goal for today. Next slide. So briefly, here's our agenda. We'll start off with the ongoing refugee crisis and its landscape with Dr. Devraj. We'll then transition to the educational opportunities here at GW and hear about Avery and Marwah's experiences in patient navigation and research. Around the halfway point, we'll pivot slightly with Dr. Batra, who will discuss the asylum process and the medical legal role that physicians and providers can have on asylum-seeking populations, and give two of our students, incredibly matched students now, Amy and Shruthi, and to share their learning experience leading the PHR student group and running the asylum initiative here, and their experiences hearing and documenting instances of trauma and torture that some of these individuals face. And then we'll give you guys time at the very end to ask any questions or follow up on anything that you guys may have, and join in any opportunities that we have to offer. So that being said, I'd like to first introduce Dr. Tanuja Devaraj. Next slide. Dr. Devaraj is an internal medicine HIV specialist physician at Whitman Walker Health, a FQHC focused on HIV prevention and treatment, LGBTQ healthcare, and primary care. She has extensive experience working with refugees as a leader in a student-run health clinic organization in Philly, as well as building curricula in immigrant and refugee health during her residency. She worked at Penn State for a while, working with a largely Bhutanese refugee population. And fun fact, for those of you that are in medicine, she is a celebrity, as she did lead the session on refugee health with the Curbsiders, which is a very famous podcast. So with that, I'll pass it over to Dr. Devraj.
All right. Can everyone hear me okay? Yay. Okay. So thank you for the lovely introduction, Dr. Truong, and I'm very happy to be here. So thank you for having me. So I'll go ahead and get started. If we can have the next slide. So I'm going to give you a background of what we are seeing right now as the global state of refugee health. So let's define who is a refugee. So that's someone who is unable to or unwilling to return to their home country due to being persecuted for reasons of race, religion, nationality, membership of a particular group, or political opinion. And this is an internationally recognized definition and provides legal protection under international law. And this is defined by the 1951 Refugee Convention and its 1967 policy that founded the basis for the UN Refugee Agency, which is the UNHCR. So once someone does have a refugee status in the country that they have fled to, they are protected under international law. They cannot be returned to their country of origin where they're being persecuted, and they have rights to basic needs like housing, education, employment, and healthcare. Next slide. This is a figure taken from the UNHCR report from mid of last year. And this is showing you the large number of people globally that are currently displaced. You can see around 2012 is when it started exponentially increasing, and we currently have 122.6 million people that are displaced in the world due to various reasons. And that's 1 in 80, so that's a huge number to give you an idea. And on the right figure, you can see in green, the largest proportion is internally displaced people within their country of origin. That's around 72 million. And then the next group of displaced people includes the refugee population, which is a total of 37 million, including the refugees under the UNHCR mandate, as well as the Palestinian refugees. Next slide. So the refugee population faces 3 stages of migration in their process of becoming a refugee. And at each stage, they experience significant risks and threats to their health. And so this is a little chart to demonstrate that. So the pre-departure phase is the phase where they're in their home country and they're being persecuted for various reasons, leading to significant health risks, often involving physical violence, psychological trauma, poverty, inadequate access to healthcare during this time period. And then the travel phase is the next phase where they are enduring usually a dangerous journey across water bodies or land to get to a safe country or region. Often here they continue to experience physical, emotional trauma, separation from their families, poor access to nutrition, sanitation, financial losses, and almost no access to healthcare. See, the arrival phase is when they have fled their country of origin, arrived to the neighboring country or their host country that's supporting them. Once they arrive, the United Nations Refugee Organization determines whether or not they warrant a refugee status or refugee document. If they do receive that status, they are placed in temporary refugee camps in their host country or neighboring country where they do have access to some healthcare, employment, and education. But keep in mind, this is very limited due to limited resources. A lot of times the host countries are low or middle income countries themselves and have limited resources to support these populations, huge populations of migration. So this whole process, to keep in mind, can be several decades. You know, I had a patient who, from when they started their process of fleeing and arriving, they were 10, and by the time they reached the US, they were 40. So it was a 30 year or 3-decade process until they had a permanent home. So significant health burden here and health risk. If they aren't granted a refugee status from the UNHCR, they can, stay and apply for asylum status, and you'll hear more about this from Dr. Batra. Next slide. So, sorry. So once they are accepted to their, a new country or their permanent home and offer permanent residency, they go through the process of resettlement. And in the US, that's run by the US Refugee Resettlement Program, which offers 1 year of support, including healthcare or health insurance, employment services, English language classes. And you'll hear more about this through Dr. Truong's clinic and the newcomer clinic. But there are several barriers to think about that are ongoing post-arrival that refugees continue to face. Some of them are, financial or insurance barriers, health literacy barriers, navigation issues, language, this leading to a huge burden of disease greater than most populations that we see that are unique to the refugee population, and that includes both metabolic or chronic diseases like hypertension, diabetes, obesity, but also infectious disease risk, including HIV, hepatitis, TB, and mental health. So next slide. Okay, and then this is a brief overview of the major challenges we're currently facing due to the executive orders from the current administration. So here's just a few examples of what it has impacted. So due to the executive orders, the refugee resettlement program through the US has completely been suspended. And so the individuals that had already been accepted and already on track to travel to the US and reach their final home or destination has been suspended, and no new refugees have arrived since this executive order. So that's a huge loss. The other programs that we're seeing that are affected by the executive orders are the termination of the temporary protection status program and the suspension of the humanitarian parole. These are both programs that offer temporary admission and stay in the United States due to unsafe conditions or humanitarian crises in their country of origin. The United for Ukraine, U4U, is a well-known program that accepted 170,000 people from Ukraine since the war has started to provide safe homes for people, which has now been suspended and can no longer accept any more individuals. Okay, next slide.
Thank you, Dr. Devaraj, for that great introduction to refugee health. And so I wanted to now kind of shift over to discuss the educational opportunities in refugee health we have here, specifically speaking about the GW Medical Faculty Associates Newcomer Clinic. So the Newcomer Clinic, I started about in, I think, October now or November, before the new administration took place. And the goal of this clinic was to provide a space for newly resettled refugees to have their first initial domestic medical evaluation, which is like pretty much their checkup here in the US to make sure that they understand the healthcare system and also go through their communicable and non-communicable diseases. And also from there, kind of make it a medical home where we can follow them along for primary care. So with that, I have partnered and found partnership with the School of Medicine, especially the medical students here at GW, and they've done an incredible job. And I'll let them talk a little bit more about what they've done, but with patient navigation specifically, as well as helping me in the clinic realm, and also with kind of initiating and starting new opportunities to expand healthcare kind of outside the clinic boundaries. As you can see here, we work really closely with local NGOs, some of them being ECDC and Dar al-Hijra Islamic Center. They provide me, their clients are the newly resettled refugees, and they kind of refer them to me when they need that health screening and to kind of have medical care from that point moving forward. Next slide. So now I'd love to introduce two incredible students, are Marwah Shuaib and Avery League. Marwah is a third-year medical student who has worked with refugees in Virginia for almost a decade. Her research centers on trauma, resilience, and healthcare for refugee women. Her work has included refugee resettlement, advocacy, community outreach, as well as clinical experience in the newcomer clinic. And then we have Avery League. Avery is a first-year medical student here at GW, and before starting medical school, she worked for the Federal Health Center program in the Department of Health and Human Services, where she supported over 1,400 health centers that provide free or low-cost primary care to underserved communities across the U.S. Next slide. So with that, let them get started.
Great. Hi, everyone. So I'm just going to take a couple of minutes to talk about the role of medical students in the GW Newcomer Clinic. So the roles available to medical students are scribing, patient interviews, and patient navigation. And this clinic flow probably looks similar to a lot of other clinics that are affiliated with GW that you all might be familiar with. But I think what is somewhat unique about the GW Newcomer Clinic as a patient navigator is working with the refugee health population, and in particular, navigating just the sheer number of barriers to care that this patient population experiences all at once, all at the same time upon arrival to the United States. So I just wanted to give kind of an anecdotal example from one of the patients that I've been working with. So this is a patient who needs follow-up care for her arthritis because she's experiencing joint pain when she walks. So to schedule that follow-up care, the first step was just finding a clinic in Northern Virginia that accepts Virginia Medicaid, which she has, because many clinics don't. The second step was reaching out to that clinic to schedule an appointment and learning that because she is a new enrollee in Virginia Medicaid, she has not yet received she requires a second insurance card for her particular managed care organization that she has not received in the mail yet. So learning that the first clinic can't accept her insurance as it is. So then the third step is reaching out to a different clinic that can accept her Medicaid insurance as it is, which is great. But then the fourth step is confirming that she is able to travel to that clinic because, for context, this patient doesn't own a car. So we looked into it, and the clinic is almost an hour from her house via a bus route and a combination combined with a walking distance. But the issue there is we're scheduling this care in the first place because this patient has arthritis and is experiencing pain when she walks. So that's just not a viable option. So then the next step is to contact Medicaid to arrange transportation services through Medicaid. But it turns out, once again, because this patient was a new enrollee, her transportation benefits were not yet active. And because I'm a patient navigator, I'm not able to make a change to her coverage, a direct change to her account. That's something that the patient personally has to do. But some added context is that this patient doesn't speak English. So she has to call herself to make this change. And Medicaid does have translation services available, which is great. But the issue that we encountered is that when you first call, you're directed to a pre-recorded menu all exclusively in English and Spanish as well, I should add. But that you have to then navigate to obtain access to additional translation services, which is another barrier for this patient. And so it kind of goes on and on. And so what I kind of learned from this experience is just sort of a new appreciation for the way that these barriers to care can kind of snowball into each other. And just sort of getting a new appreciation for the fact that I think, I think we talk in a lot of different classes and a lot of different clinical settings about social determinants of health and some of the challenges to, medication adherence or attending appointments. But I think this experience has really driven home for me that it's really that so many stars have to align for a patient to walk through the door in the first place. And my hope is that I'll be able to take this sort of kind of added level of empathy for patients forward into my future practice, whether it's with refugees or not, and no matter where I practice, that this kind of empathy, I think, should apply to all patients. And that's something that I'm hoping to take forward from this educational experience. So with that, I will pass it over to Marwah.
Thank you, Avery. Can we get the next slide, please? So I am going to be talking about a specific example that I had working with the refugee community in Northern Virginia. And it was a research project that I did in the summer of 2023. So the summer after my first year of medical school, concerning resilience and refugee women. And I interviewed refugee women who had resettled in Northern Virginia between 2021 and 2023. I worked with Dr. James Griffith, who's a psychiatrist at GW and who has a lot of experience working with refugees, immigrants, and survivors of political torture, and talked to women from a variety of ethnic backgrounds, educational backgrounds, I spoke with people's, husbands and children, and kind of got a very comprehensive overview of what women in this area were dealing with in terms of resettlement. Some of the topics that we covered included their experiences prior to and during migration, the specific health concerns that they had had related to their migration and beyond that, and questions about the stressors and protective factors related to displacement and resettlement that are very notable in the Afghan community. And that's kind of where the resilience piece came in. We can go to the next slide, please. Just to provide some local context for this work in the Northern Virginia and the DMV area specifically, this area has been a hub for Afghan arrivals for many years, kind of predating the 2021 withdrawal of US troops from Afghanistan. The Virginia has the second largest Afghan diaspora community in the US. And in 2021, when we see this sharp increase in arrivals and this massive need for services, the community really mobilized. So there was a lot of kind of individual peer-to-peer support being given in local religious organizations, local shelters. There were community members mobilizing to create warehouses where stacks of donations were being distributed every day at a very large level. Some of the healthcare needs of these new arrivals included the domestic medical exam, so these kind of preliminary screening exams that were done when people were newly arrived, establishing primary care, which was a huge barrier for a lot of people just in terms of finding people who were taking new patients, getting appointments, and just the process of making appointments, as Avery was mentioning. And then addressing mental health needs among newly arrived people, which is a very fraught topic among a lot of refugees, and particularly from what I was seeing in the Afghan community. Go to the next slide, please. Some challenges that I encountered in my research and that I think a lot of people have encountered when attempting to do research with refugee communities, and that kind of might give people hesitation in doing work like this, is that it is difficult to establish trust and to build rapport with these communities because you are approaching them as an outsider. And that's something that it's difficult to navigate. It's something that relies a lot on mediators and people, within those communities who can kind of bridge some of those gaps. There is a lot of stigma around the topics that I was asking people about and the topics that are, very central in a lot of this research. So mental health, reproductive health, family planning, and the experiences that people had when migrating, particularly when we think about like the ongoing trauma of displacement. A lot of people that I spoke to had been held in military camps for months before they had been resettled, and they were very hesitant to speak negatively about that time. And this kind of there's a cultural kind of field that needs to be approached very sensitively when working with this population. Next slide, please. Some of the biggest takeaways that I had from my experience and that I kind of advise other people on is that it's really important to approach this community with a lot of humility and respect. It is not easy to share stories of migration. It's something that can be very re-traumatizing for people. So you have to approach it in a very certain way and, really appreciate what people are doing in sharing their stories with you, because they're sharing stories because they hope that it'll help other people. Community partners are very critical in doing this work, something that I think everyone who's worked in this field, either clinically or in terms of research, will tell you. I was very lucky to work with resettlement people at ICNA Relief, which is a local organization, as well as a case manager at Lutheran Social Services, who helped me find a lot of the people that I spoke to. And I also was very lucky just to meet people in my day-to-day life who were able to help me find people to talk to and kind of, give me a little bit more legitimacy in the work that I was doing. And finally, I really think that more of these stories need to be captured and told. There is a very rich field that I think has not fully been explored in terms of research relating to refugees, particularly populations like refugee women, who are often overlooked in a lot of the academic literature. And so I would really encourage anyone who is interested to take the steps to tell more stories like this and to do more of this work. Thank you.
Next slide. Thanks, Marwah, so much for those stories, and thank you, Avery, as well as for sharing. So now I was hoping to kind of direct our attention towards asylum here in the DMV. So let's start the discussion with Dr. Sonal Batra, who is an associate professor of emergency medicine and health equity and social emergency medicine section chief and fellowship director. She was the founding member of the Beyond Flexner Alliance, an organization dedicated to advancing social mission in health professions education, and is interested in diversifying the healthcare workforce. She volunteers her time with the Physicians for Human Rights Asylum Network, conducting forensic medical evaluations to corroborate asylum seekers' claims and persecution of torture. So I'll let you take it from here, Dr. Batra. Next slide.
Hi, good afternoon. Sound is fine. I think that is yes. Okay, great. Thank you. Thanks for the introduction, Gavin, and thank you all for joining us today. So I am going to pivot now and spend just a few minutes speaking to you about what it means to seek asylum and then become an asylee in the United States. There are some important differences between this population and refugees that you previously heard about, though also a lot of overlap. So a person becomes an asylum seeker once they arrive either inside the United States or at a port of entry and request asylum. And they request asylum because, similar to refugees, they cannot return to their home country for fear of persecution. So a key difference is that refugees get approved prior to arriving in the US, whereas someone who is seeking asylum comes to this country first and then requests that status. And it's important to note that this is legal, right? This is legally allowable under both US and international law. So it's not illegal to come into the US without prior authorization if you are doing so seeking asylum. And then once a person seeking asylum has their case heard, and if they are approved, at that point they become an asylee and have similar benefits as those provided to refugees. Next slide, please. So this is just an idea of what the timeline can look like for someone in the US seeking asylum. You have to apply within 1 year of arrival in the US, though many people apply pretty much immediately on arrival. And then on average, it can take about 6 months for you to have your initial interview with the US Citizenship and Immigration Services officer. And at that interview, the officer determines if you meet the definition of an asylee, which is essentially the same as that of a refugee. So they're making sure that your claims of fear of persecution are credible, and also that there are no bars to you being admitted to the US, such as any issues with your background check, or if you were previously denied asylum by an immigration court. And at that point, after the interview, you're either approved and you become an asylee, or you are denied and you can appeal that, or you're referred to an immigration court because they've decided that the officer can't make a determination and it needs a more thorough review. So if you're approved, you become an asylee, and at that point you're able to work and obtain federal benefits. But if you are referred to an immigration court, you remain a person seeking asylum. So your status is still sort of in this middle ground, and on average wait another 2 years for your court date. And these are averages, and so as the number of asylum seekers vary year over year, so do the wait times. And you can see from the last number on here, on average, it takes about 4 years for those who are eventually granted asylum in the US to get that status. And during that waiting period, they can't access federal benefits such as WIC or Medicaid. They can work, but only after a 6-month waiting period, which can obviously be a long time without income and without access to any kind of federal benefits. And so there are anywhere between 1.5 and 2 million people who are in this in-between status who have pending asylum cases. Next slide, please. So to give you an idea of trends in US asylum cases over the past few years, paralleling what we see amongst refugees, the trends are often driven largely by major geopolitical events. Right? So you heard about specific programs for folks from Ukraine and from Haiti and Venezuela. And you can see from the numbers here, as an authoritarian regime took hold in Venezuela, there was a huge influx in asylum cases from that country. And so these things can change very rapidly depending on what's going on around the world. And that, in addition to changes at policies at the US southern border, contributed to a significant rise in asylum cases over the past few years. And you can see that sharp rise was primarily in what's known as defensive asylum cases. So these are cases that go through that second step that I described before, where they don't get initial approval by an officer at USCIS, but rather need to go to an immigration court. Next slide, please. And so those cases that are going to immigration court for what's called the defensive asylum process, or that second step, is where the role of the Physicians for Human Rights Asylum Network comes in. So this is a national network that I and several other faculty members at GW are part of. I've been doing this actually from the year I graduated residency, which has now been about 10 years. As we already described, people who seek asylum do so because they have a fear of persecution if they return to their home country. And when they're going to court, their job and the job of their attorney is to prove that that fear is credible. And many people have that credible fear because they've already experienced persecution and either been physically or psychologically tortured prior to coming to the US. So with any court appearance, if they can gather evidence to prove that they've experienced this, it can go a long way in convincing a judge that their case is valid. And so that's what we do. We use our skills as physicians and other healthcare providers to provide that evidence by conducting a forensic medical exam. Every month or every few months, a staff member from PHR, Physicians for Human Rights, sends out requests to all of the volunteers in the area who are part of this asylum network. And it includes a list of the people who are seeking an exam to support their case. And as you heard Marwah really wonderfully describe, these can be really intimate and challenging experiences because you're privy to details of people's lives, including specific detailed descriptions of their experiences of torture. And so some of the clients that I've worked with include a young man who was arrested due to his political beliefs and was shot and beaten while he was in custody of the authorities. Others include a woman who had female genital mutilation, and she feared her young daughter would be subject to the same if they went back to her native country. And so my role is essentially to do a history and a physical exam. So using kind of the skills that we all have, and then carefully document my findings in an affidavit, which the client can then submit as evidence in their court case. So I'll document scars or other sequelae of injury and then describe in my professional opinion and with the training that I've gotten from PHR, how well it fits that person's statements of what happened to them. And I think it's important to know I don't comment on the political situation in that country or really any of the surrounding details because that's not my area of expertise. So it's really just based on what I, as a physician and with some additional training from PHR, can conclude. One of the exciting developments in this over the past few years is the student PHR chapter, which I think Amy and Shruthi are going to talk to you about next. The next slide, please.
Yes, and I agree with you, Dr. Batra. I didn't realize I had the skills to kind of do these exams. And once you kind of do one and you kind of get the feel of it, it's pretty easy to get into. And the best part about it is that it's really flexible. So it's not like clinical care where you have to kind of do a set amount every week. If you feel like you have some downtime once in a while and you want to do an exam, you can do it. So it's really flexible. So with that, let's transition to talk about the GW Asylum Initiative that Dr. Batra was talking about with Amy Yee and Shruthi Voleti. So Amy is a fourth-year medical student and the president of the PHR chapter at GW. She's going into pediatrics, just matched. She's very passionate about immigrant health, healthcare navigation, and improving the access to care for individuals with limited English proficiency. And then we have Shruthi, and Shruthi is also a fourth-year medical student and was the VP of the PHR chapter here at GW. And she just matched into her residency in emergency medicine. So her interests include improving healthcare delivery in urban settings with a focus on immigrant health and addiction medicine. So I'll pass it over to you guys. Next slide.
Thanks, Gavin. Hi, everyone. I'm Shruthi, one of the medical student leaders of the GWHRI. So we're a primarily medical student-led group that organizes and conducts the free forensic medical evaluations for asylum seekers, like Dr. Batra was talking about. So we provide these evaluations pro bono and work with attendings, residents, medical students, along with the client's attorney to help set up the evaluation on behalf of the client. We also have branches that conduct patient navigation after the evaluation to connect clients to healthcare, because what we're doing is in the legal space and we're not technically providers. We also wanted to be able to connect clients, not our patients, to providers, so they can fill in those gaps. Oh yeah, can we get the next slide, please? Thank you. as well as branches in advocacy work, community outreach with local organizations. So really students have the opportunity to provide their skill set in any number of areas to uplift asylum seekers and potentially bring them a step closer to securing asylum. And we're also in the process of expanding to the undergraduate student body at GW as well. Next slide, please.
And so the group was founded in the late fall of 2023. So we've been around for about a year and a half. And since then, we've been able to complete 16 evaluations with actually a couple currently scheduled. We have 19 faculty and resident evaluators and 23 trained student scribes and/or patient navigators. And I think the really cool part of being able to do these evaluations is that an asylum seeker who receives an evaluation through the PHR network has about a 90% success rate in comparison to the national average of 30%. So that's 3 times as more likely to have a successful case in comparison to the average. Next slide, please. And so kind of in my own experience being able to be a part of this group, I think as a future medical provider, this group has really not only taught me, I think, the more superficial parts of being the intersection between medicine and the legal system, kind of how I can make a difference in the lives of my own future patients by conducting these evaluations. But I think also understanding a little bit better about what trauma-informed care looks like. During these evaluations, it can be a very challenging time for clients to be able to talk about kind of what they have suffered in their past. And I think you really have to learn how you can be able to create a safe and supportive space for your patients and your clients to be able to talk about what they have experienced. And when I think about a case that I've done in the past, we had a client who had fled his home country after facing severe persecution from his dad, who was pretty powerful and also got the government involved for being part of the LGBTQ community. And while this client had physical scars that you could easily see, I think as you spoke with him, you can quickly see how there was such a large psychological toll on him also. And I think as a future clinician, I realized my role not only as someone who can help validate his experience, but also support him in his fight for asylum. And you realize how resilient individuals are in his ability to be able to share about his experiences again. And at the end of the evaluation, he was still crying from talking about some of his experiences. But he asked if he could hug everyone in the room. And as he was hugging everyone, he just couldn't stop expressing gratitude, saying, "Thank you so much for doing this and taking the time." And he was also saying just being able to talk about it was really just kind of felt like a weight had been lifted off of his shoulders. And I think for me, it was just amongst many things, a strong reminder of how compassionate patient-centered care, even if it is such a short time, it can be a powerful force for justice and healing.
Speaking of powerful forces for justice and healing, I've also really enjoyed working and learning from our community partners, as that's a big part of who we are as GWHRI, and being part of movements in DC to support the asylum seeking community here. I'm definitely leaving with a better understanding about how to educate myself and my peers, especially future healthcare providers, given the evolving landscape as it relates to refugee resettlement, migrant health, and knowing patient rights in healthcare spaces. For me, it's hard to pick any one client story because everybody is so memorable, everybody's so different, and I learned so much from each encounter, both about the process and from each person. I think my most recent evaluation stands out to me for 2 different reasons. First, because I was one-on-one with the attending for whom I was scribing with. Usually we have like 2 medical students, maybe a resident and a medical student. That day I was just with the attending, and as we were chatting about the case, he kind of got the sense that I had done a few cases, and he kind of offered to me as he was interviewing, for me to jump in and fill in any gaps as he was talking to the client. And I was really pleased with myself to see that after doing a number of cases, I've really learned a lot about the appropriate questions to ask, how to ask them in a way that, you know, re-traumatizes the client the least, but also you are getting the information that needs to go into the affidavit, so that I was like able to contribute meaningfully during the client's case itself. And that was really important for me as someone who hopes to do this in the future. Because of this, I also felt like I was able to create a more comfortable client evaluator relationship. I think this client was somebody who was being persecuted by the police in his country for standing up to an authoritarian regime, and he was being tortured for information as a result. And it was a really interesting case because, like, as I was being more involved in asking the questions, I was really thinking about, like I said, how to re-traumatize the least and also get the most amount of information that would be important for the evaluation. And I felt like I was able to do that. And after the case, the client was really thankful and had a lot of gratitude for how we were helping out in his process. And that always makes it very worth it. Yeah, next slide, please.
All right, so I know you guys are drooling at the mouth with questions, so please feel free to put it in the chat. But the most important thing about this webinar was not only to uplift and share some stories that our learners were having, but also ways for you as, you know, learners from all levels, students and faculty, for you guys to get involved. So use this fancy QR code I created. I think we're gonna have a link in the chat as well, so you can kind of get a more curated detail what we have to offer. I'm not gonna go through everything, but things include, you know, collaboration clinically, community projects like me and a few of the counselors over at G-Shed. We're hoping to do some form of like art therapy, as well as creating a community garden for the patients at the newcomer clinic. So that's something I'm looking forward doing. Also as students, you know, shadowing, obviously patient navigation as well. And then same thing from the asylum side of things, you know, connect with GLW PHR student group and we kind of get you guys in. So take a look at that when you guys have a chance. There's a lot of good information there. But again, I just want to like emphasize one of the most powerful aspects of this works is the partnerships that we can build across these disciplines. So whether you're a student, a physician, a advanced provider, legal professional, NGOs, community leaders, we all come together for the same goal. So we really want to make sure that this community strives and thrives here, given their situation. Each of our panelists today kind of represents a connection I made through the shared mission. So I hope this webinar serves an opportunity for all you guys listening, whether an expert or not, to kind of get involved. Next slide. And so with that, we're about to open up for some questions, but I just wanted to introduce to you guys our next webinar, which is going to be moderated by Dr. Bernd Schmidt, GW Radiology, in experiences with radiology capacity development in low-income countries. He will showcase his work that he has led through his charitable organization, Humanitarian Radiology Development Corps, leading to impact and sustainability in various countries, including Haiti and Togo. And that should be coming soon in about May, June. So hopefully we can have that for you. Next slide. So feel free to keep spilling in the chat. We still have about 15 minutes, which is the perfect amount of time. So our team did very good on timing. So just to see a few here. Allison asked, are there opportunities for PA students to be involved? Absolutely. As I said, you know, whatever it may be, we'll find a way to get you involved. Take a look at the resource section. You know, we have contact information on there as well, and we can kind of get you guys connected. We have a question here. So great webinar. Thank you all. Few questions, and then we'll start with one at a time. Is there still a risk of deportation while people are waiting for asylum approval? The second question is, are there opportunities for non-GW physicians to collaborate with you, especially in the setting of forensic medical exams? And the third thing is, what are some resources that inpatient providers should know about when caring for refugees and asylum seeking patients?
I'm happy to jump in on the first part. The caveat of I'm not a lawyer, none of us are lawyers, and there are a lot of nuances here, but Generally, the answer is no. If you're waiting for asylum approval, if you have an active case, you are generally protected, but there's lots of exceptions, including if you are arrested and charged with a crime that can lead to expedited removal or other statuses, and there's sort of an evolving landscape around this, but having an active asylum case should generally protect you from deportation. I can jump on the second, but then I don't know if the students have more on this. But for non-GW physicians, just one easy thing, and I don't know if it's in the resources section, is to join the Physicians for Human Rights Asylum Network. It's very easy. I think the training is now fully online, and it's about 8 hours, or at least that's what it used to be. And there's really not a whole lot of skills that you need outside of what you already know as a physician. And then the additional skills that are provided in the training. And typically, physicians who are new to this will shadow an exam or two, or sometimes do one kind of with a buddy system with someone who's more experienced before they start doing them on their own. But it's a pretty low barrier to entry. The application is available online.
And I can kind of, maybe Dr. Devaraj is better.
Yeah, we can both jump in. Maybe you have, so I'm an internist, so I used to do both outpatient and inpatient care. So when you see patients on the inpatient side and you hear about their refugee history, or they're in the process of seeking asylum, so it depends where in their journey you're meeting them. If they are a former refugee and they're in the US, which means that they've already been granted permanent residency and are in the process of, getting their US citizenship. So the main issues there is after the 1 year of support they get through the refugee assistance program, they fall through the gaps and don't know how to get health insurance through, healthcare exchange or Medicaid or Medicare. So that might be some resources to help them get those access to insurances and then access to primary care. If they don't meet those requirements, there's a lot of federally qualified health centers, including the one I work at, which take uninsured patients as well, so they can get access to primary care. So that's definitely a resource to help former refugees be connected to ongoing primary care. For asylum seeking, I think it depends. Sometimes I meet patients, they are very well connected. They already have a case manager. They're connected with a nonprofit legal organization who's helping them. But sometimes people have fled their country, they're undocumented, and they don't know about the asylum process, or they don't know that they could be a candidate for asylum process. So connecting them with a nonprofit or a legal organization. I have one for a medical legal partnership in my clinic, so I don't know as many resources in DC, but I don't know if Gavin or Dr. Batra have resources for medical legal partnerships in the DC area.
Yeah, thank you for that. And I agree with everything you said. I think that one thing to keep in mind is that people, especially in the hospital inpatient side of things, it doesn't matter if you're insured or not. So the history is going to be the most important. So if you're listening in on this call, that means that you should be starting to ask people about migration history, insurance status, socioeconomic status. That should be just a routine part of your H&P, because it's an important detail, that social history. And then when it comes to the legal side of things, if someone wants to know more about asylum, there are some local nonprofits here in the area that can support. Now, again, with recent executive orders in place, I'm not sure at what function they are. Even before these things happen, a lot of the local legal aid that we were getting referrals from, and I think maybe Amy or Shruti can give us more details on it. There was a big backlog, and there was actually some I think Asylum Works is one, they stopped accepting new asylum clients, asylum seeking clients. So, and then now with the cuts on aid, those places may be maybe half or more of the staff can be completely furloughed, like other resettlement agencies here. So it's really tough, but social work is always your best friend when it comes to the inpatient side of things. So if you can get them to help you as well, but just hopefully there will be a time where a lot of these resources will be kind of allocated in an area, and that can be maybe a project that someone works on, getting all these resources in one area in the DMV, and then having that as a good resource for those rotating through, especially at GW's inpatient side of things. Okay, and for the next question, Da, da, da. Do you anticipate any further hesitations or lack of engagement from refugees asylees given the current policies and operations of mass deportations? What do you recommend to clinician researchers to keep their information and keep them safe while planning research or providing care for them? What a great question, by the way. It's a tough one. It's a tough question, but it's a very good question. I can speak a little bit on this too, and anybody else can chime in. But so I working with both groups. For me, the hesitation or lack, I can foresee, especially with asylum seekers or those are in the process of asylum or haven't claimed asylum but have gone through persecution or planning to give asylum, there will be that hesitancy to kind of reach out to anybody else outside of their known network, right? So like it's it's a true fear that people have. I work with a group of people who work at this who live at this NGO called Mary's House, and the CEO of that company just took on, I think, like 40. They're now like parents of 40 kids just in the case of one of their family members being deported. So and they did that because she's the only person they trust, and even like people on the outside, the providers and things, there's no trust there sometimes just because of the given nature. So I suspect that there will be a lack of engagement in the medical care system to be worried about being deported for whatever reason, or even those that have legal status here can get legally deported now, I guess. But it's there's guidance given by there's attempts at guidance given by national organizations, like the Society of Asylum Medicine is very good about sending information through emails and through their website on like how physicians can be informed of what to do when someone's facing deportation. How can you advocate for them? Those kind of things, those advocacy websites that's listed on the resource page has got a lot of good information there. And then just, I think the big thing is, finding partners, legal partners that are engaging with, like immigration lawyers that are engaging with this population regularly and getting their guidance on things as well, and planning webinars and sessions to educate us providers at a mass and students at a mass to kind of get us aware of that.
I'll just go ahead.
Oh, go ahead.
I was going to quickly add to the patients, providers, and like clinics have rights to like protect all information. So if like an ICE officer shows up at clinic, like they don't have rights to access any patient related information. So I have several patients who are like, I'm afraid to leave the house. I don't want to come to my doctor's appointment. And this happened in the first Trump administration as well, when I was working in New York. So it's just, having policies like in your clinic so that the front desk or the security know that they are not allowed to share any patient related details. So offering that security to patients, and then also offering telehealth, which is what I do for a lot of patients who are afraid of leaving their home. But yeah, it's definitely, clinics are supposed to be safe and hospitals are supposed to be safe havens.
Yeah, and then just building on that in terms of documentation, I think this might address both Jill's question and also Shiksha's question in the chat. Is that I think generally when it comes to specifics around migration and what happened or their legal status, I think less is more in terms of documentation. That information obviously is protected in the medical record. However, that doesn't mean that it's totally inaccessible. And I think, we give the same advice when it comes to patients describing interactions with law enforcement. Anything in theory, if that document is accessed and there's something that is contradictory in what's in the medical record and what's in some other document, those things can work against a person in terms of their case. And obviously, details of things that happened 3 years ago and the specific nature of the torture can be really hard for people to pin down and remember, especially given all of the trauma that comes along with that. And so if the specific details aren't relevant to what is happening medically, then I think that there's generally no need to document that. But the forensic medical exam is a little bit different. So there isn't really malpractice concerns because we're not providing any medical care in doing that forensic medical exam. It's really just documenting what has happened. I'm not treating anybody in that. And so with that, then there are a lot more details that we are documenting because the entire aim is to support their case for asylum. But even in those cases, if there are specific details that are irrelevant or contradictory, we try not to include them for that same reason. We don't want, one statement saying that something happened in February and then a different statement saying something happened in March. And again, it can be very difficult to keep all of those details straight.
And then just a couple things to add. We were on a meeting with the national chapter for PHR, and at least through PHR as of now, they were saying that they're seeing the same number of evaluation requests come through as previously. And so while this may change in the future, like as of now, evaluation request wise, we are still like at the same numbers that they've always been at, even with changing climate.
And maybe we have time for maybe like one more question. Let's see. So here's a question. How can uninsured asylee seekers access outpatient care with your GW practice or with subspecialty care at GW? So right now, that's still a work in progress. In the newcomer clinic currently, we're able to see them because we accept Virginia Medicaid. But I think have to be a discussion with people much higher than I to discuss, whether there will be space for uninsured patients to come see us. So right now we don't see uninsured patients, and that's why we have a lot of FQHC support across the area for those that don't have insurance or have really bad insurance that need help with their care, and they can go with them, but that also comes with limitations. Dr. Devaraj works at FQHC here in DC, and I'll let her speak on that if she'd like. So even though we cannot see in our clinic, there are hopefully other options around the area that they can get to and the great thing about FQHC is that really great wraparound care that right now my clinic is still building upon.
Yeah, absolutely. There's several really good FQHCs in the DC, Virginia, and Maryland area. So I'm at Walker Health, which does primary care, HIV prevention and treatment. But FQHCs are federally qualified health centers, so anybody, regardless of their immigration status, insurance status, can be seen. And it's a sliding fee scale. So some of my patients pay $0. Some of my patients pay $10 to see us. And a lot of clinics have, dental, GYN, some subspecialty care built into their FQHCs, and a pharmacy built in. So it's not, it's not end all be all, but it is a huge community resource. Yeah.
Great. Do we have any more questions? Let's see. I think we talked about my practice a little bit. Got access to the recording, talked about the charting. How has recent administrative changes impacted your work directly? Let me just speak on that as a close, not to like bring any downers here, because I'm still working strong. I'm still trying to get the community up and going, the clinic up and going. But yeah, it's affecting my clinic directly, right? No more referrals from from resettlement agencies means no patients for me to see. So there's no newcomers here, right? Funding cuts for these resettlement agencies mean that 75% of the staff that I've been working with has been furloughed. So the people that I've been working with daily on are no longer there. One thing is that recently with some of the executive orders is that the patients that were receiving RMP money for rental assistance, first 3 months of rental assistance, that's been taken away from them. So they were guaranteed 3 months rent when they first come here to the US to help them, build livelihood so they can find jobs and get work and be able to kind of self-sustain. But that has been taken away from them. So the patient I saw today, this morning, he was asking me, they're worried about getting kicked out of their $3,000 a month apartment for him and his family of 8. So, and how do I deal with that kind of concept? So, these are kind of things that are, dynamically happening and things are changing. And hopefully 90 days from when these orders were placed, we can have a second look at them by the administration. But all I can do right now is do my advocacy and do my part in trying to help. And I think that's where everybody's role here who's listening on the call, there's room for them to help. To jump in and join in, and because I think as a team we can do it, but it's tough. It's definitely not easy. but the patients are amazing and they make work worthwhile, and this community is very resilient, uplifting. So it's something that I hope that we can inspire others to get involved with. And with that, I don't know if anyone wants to talk, but with that, I think we're good to go. Thank you guys for staying, guys. Take care.